So plantar fasciitis is the most common cause of adult heel pain, and generally is pain as it relates to the attachment of a broad ligament called the plantar fascia that attaches to this region of the heel, as well as to the central and outside portion of the heel. Pain associated with plantar fasciitis generally tends to be worse when you just get out of bed in the morning, or if you've been sitting for a while and get up on it. And itis relates to inflammation of this plantar fascia, this ligament as it attaches. The causation for plantar fasciitis has a lot to do with the inherited mechanics of the foot, and we talk about excessive pronation of the foot. And during walking, essentially, heel to toe into propulsion is at the mid portion to propulsive phase of walking that we see excessive pronation. A majority of patients who come in for lower extremity injuries tend to pronate excessively, and that's easily likened to someone who has a flat feet or flat foot. You don't have to have a flat foot to have this problem, but it generally is associated with someone who has more of a collapsed or pronated foot. The focus of diagnosis is really identifying the areas of pain, predominantly in the area that I've drawn. We also really want to make sure that the patient doesn't have pain on the inside portion of the ankle, which can be more associated with a nerve problem called tarsal tunnel. And very rarely do we see stress fractures or broken bones of the heel. And usually a stress fracture is diagnosed by having pain as we relate to squeezing or compression of the heel. One misnomer that many people talk about is they really talk about their quote-unquote heel spur. It's not uncommon, about 10 to 11% of people walking around, if we took x-rays, would actually have spurs on the bottom of their heel. But the spur, as it relates to the attachment of the plantar fascia, and here's a skeletal model showing a bone spur, but really it's the broad ligament itself, the plantar fascia, that attaches to this region, that over a period of time will cause the bone spur. Traction on that area will cause the bone spur. But when we talk about the causation of plantar fasciitis, it is not related to the bone spur. In fact, a very small percentage of patients don't do well conservatively and go on to have surgery, and we always leave that bone spur, so we don't take that bone spur off. There are very few instances where we do. And plantar fascial surgery in a very small percentage of patients really is a very straightforward process of actually cutting the ligament from the inside to the central to what we call lateral portion of that plantar fascia. But traditional treatments for plantar fasciitis are anti-inflammatories, ice once or twice a day, generally 5 to 10 minutes around the heel. Frozen water bottle is a great example, or a great treatment. We'll use oral anti-inflammatories like Advil and Motrin, generally at prescription strength for a period of 10 days to 2 weeks to decrease the inflammation. And very cautiously, we'll inject cortisone. Cortisone is a very valuable tool in many patients who have very acute localized pain to treat the plantar fascia, plantar fasciitis, and we can inject cortisone once, twice, maybe up to 3 times over a 6-month period of time before we don't use that as a very viable treatment tool. Many patients will actually have had their plantar fasciitis for a long time. WebMD suggests that it's a year recovery for people who have plantar fasciitis, but we really want to throw the kitchen sink at this problem specifically. Anti-inflammatories as treatment, but then what we really try to do is use a shoe and an orthotic as a tool to help decrease pronation and decrease the mechanical stress on this plantar fascia. We use a fracture or a broken bone as an analogy. If you have a broken bone and there's movement, the break or the fracture will never heal. So to heal a fracture, we immobilize you either by putting a screw or a plate across a fracture or putting you in a cast. When the fracture has healed, by preventing movement, the cast is essentially removed. When we remove the cast, you go on about your normal life. This is not a fracture, but we use a really well supportive shoe with good support features built into the structure of the shoe, plus an orthotic. And the orthotic, by bridging your arch, okay, and the support structures of the shoe, what we're trying to do, if this is the plantar fascia attaching the heel to the base of the toe, we're trying to decrease some of that foot pronation. And so by contouring the arch, lacing up around the foot with a good structural shoe, you're decreasing the tension on that plantar fascia. So decreasing stress on the plantar fascia plus the use of the anti-inflammatories are the two vehicles that we use for recovery for plantar fasciitis. We'll very occasionally use custom-made orthotics if patients don't do better. We'll oftentimes use a night splint, which is a rigid tool or a brace to keep that foot stretched out at 90 degrees to the leg at night. And a night splint is a really good way to help keep those pain receptors that are inflamed stretched out, so the initial weight bearing that you have in the morning is without pain. Generally, patients should really see significant improvement with their plantar fasciitis within the first 6 to 8 weeks of treatment. The other thing that we really want to emphasize is calf flexibility. Really very important to do calf and or Achilles tendon stretching over the period of time of treatment. It's a very important tool to increase flexibility through the calf, as well as to decrease some of the stress on the soft tissues themselves. Physical therapy, formal physical therapy is sometimes needed also to help improve the symptoms associated with plantar fasciitis. But again, shoe and orthotic therapies plus anti-inflammatories, as well as activity modification, low impact activities like bike or pool, stationary bike, spinning classes are great ways to stay in shape, but also allow this to rest and recover.